Just want to thank everybody for joining us today, and we'd like to begin with introductions. My name is Mandy Weeks-Green. I'm the Board and Commissions Director, which means that I oversee both the Universal Healthcare Commission and the Healthcare Cost Transparency Board. And I'll turn it over to Rochelle Bogue.
Hi, everyone. I'm Rochelle Bogue. I am the Cost and Transparency Manager. And I'll turn it to Ross.
Hello, I am Ross McCool. I'm an analyst for the Healthcare Cost Transparency Board.
And has Cheryl had the opportunity to rejoin us yet?
I don't see her on here.
Okay. Jingping? Would you like to introduce yourself, Jingping?
Hi, I'm Jingping. I'm Cost and Quality Analytics Manager in the HCA. So we are a team providing the data support for the cost board. Cheryl is, I think she's having some technical difficulties right now for her computer.
Well, hopefully we'll get her back shortly, and we'll begin with her introduction when she gets back. All right, next slide, please. Next slide, please, Ross. Uh-oh, Ross. Oh, there we go. Thank you, Ross. So we'll start with today's goals for today. We are holding this meeting to provide guidance to carriers for a successful data submission. And today's webinar will include technical guidance, and then we'll review the data submission template, and we'll also answer any questions that you might have. I will provide this opportunity both during the presentation, so please raise your hands if you have any questions, and we'll unmute you for the questions. But we'll also have an opportunity for Q&A at the end. Additionally, if you'd like to review this training in the future, we'll be recording this training and posting it on the board's webpage. Next slide, please. Sorry, I'm receiving messages from Cheryl. So for today's meeting, we have the agenda here posted. We'll provide an overview of the Healthcare Cost Transparency Board, just provide you with some background for those who might be unfamiliar with the cost board. Then we'll dive into the data call for 2024, including the reporting timeline, a detailed review of the technical manual and the data submission template, specific guidance on provider attribution, truncation and error calculations, and we'll also cover consistency checks. We'll have some additional Q&A opportunities, as we just talked before, at the end, and we'll also discuss office hours for additional follow-up questions that may occur to you at later times. Next slide, please. So as background, we'll begin with an overview of Washington's healthcare cost benchmark. Next slide, please. So the Healthcare Cost Transparency Board was established by the legislature to create a benchmark or target percentage for growth, and to analyze total healthcare expenditures in the state of Washington, and to identify trends for healthcare cost growth, with the idea to help the state of Washington control healthcare costs. And in doing that, the board must identify entities that exceed the healthcare cost growth benchmark. Where's the board currently at in this process? So the board established the benchmark for years 2022 to 2026. It has already conducted the pre-benchmark analysis of total healthcare expenditures for the years 2017 to 2019. And the board also identified trends during that period. This specific data call gathers data from 2020 to 2022, which will include the first year of benchmark analysis for the year 2022. Next slide, please. So board membership is governed by the legislation, which is comprised of governor-appointed agency and purchaser representatives. The board is advised by 3 formal committees, including the Advisory Committee on Data Issues. This committee will provide expert analysis to the board on data calls and analysis of existing data sources in order to determine the cost drivers in the state of Washington. And then we have the Advisory Committee of Healthcare Providers and Carriers. which provides expert advice from the provider and carrier perspective to inform the creation of the benchmark and supporting the data calls. The Advisory Committee on Primary Care will develop recommendations related to the state's 12% primary care spending growth target for the board's review and consideration. The board also wraps up its recommendations into its annual legislative report for the legislature. Next slide, please. The benchmark data call is conducted annually and requires carriers and other entities to submit healthcare data to the Healthcare Authority. This data is utilized to calculate the state's total healthcare expenditures and measure benchmark performance. The benchmark is a specific rate of spending growth that carriers and providers will be held to and should try to stay under to make healthcare more affordable for Washingtonians. And here in this chart, you can see what the rates are from 2022 to 2026 as established by the board. Next slide, please. Here is an illustration of the benchmark cycle from data collection to reporting out on the data and then utilizing the data to help control costs in the state of Washington. And then each year, the cycle will renew and begin again. I will now hand it off to Sheriel, who will introduce herself, and to Ross for the portion of the next webinar.
Mandy, I think we're having issues with Sheriel joining as a panelist for some reason.
Okay, let me try again. Hold on just one second and I will try. Just give it 1 second. Hi, Sheriel.
Guys, sorry for the technical problem, but I'm ready.
Sounds great. Sheriel, I don't know if you heard, but I gave our portion of the presentation just to keep the ball rolling while you were having the technical issues. We just landed on the part where I turn it over to you and Ross, but I want to make sure to give you the opportunity to introduce yourself.
Sounds good. And for some reason, I cannot turn on my camera, but I can proceed from here at least. Hello, everyone. My name is Sheriel Lamingit, and I'm the Health Economics Research Manager for the Cost Board. And I will be discussing the details on the 2024 data call, and Ross will also be explaining some parts of it as well. So for the 2024 data call, this is the second data call after we conducted the first one in 2022. The 2022 data call collected 2017 to 2019 data. Next slide, please, Ross. For this year's data, we aim to collect 2020, 2021, and 2022 data, and that will be added to the historical or baseline data, which we collected in the last data call. We'll also compare, next click, Ross. We'll also start comparing the 2022 data that we will be collecting this year to the set benchmark growth rate that was set by the Cost Board. Next slide. So the timeline of the data call is as follows. The data call started with the launch on February 12th when we sent the letters and data submission instructions and deadlines. The deadline is May 15, which was extension to the original deadline that was set on April 15. So carriers have now 90 days since the data call to prepare and submit the data. Next. After we receive the data, we plan to conduct data validation and expect to finish by July. And then we will proceed to the analysis and the generation of carrier and provider reports, which we will share to carriers and providers. After we receive feedback from carriers and provider, we'll also do the analysis that we will report to the board before the year ends. Next slide. To aid submitters on how to submit the data, we have written the technical manual, which provides more details on the program, as well as the data submission guide for submitters. We will talk more about this in the latter slides. We also provided the data submission template, which is an Excel file that carriers need to populate and submit for this data call. We also have an FAQ to answer frequently asked questions. This page will be updated regularly to reflect new frequently asked questions that we may receive from carriers. We have provided the links to these materials in our official data call letters. Ross, if you can provide the links as well in the chat, that would be helpful to the attendees. Next slide, please.
Sheriel, chat is disabled for webinars.
Oh, okay.
Is there something more that you would like us to do at this moment in time, or can we send them out afterwards to everybody on this group? Would that be okay?
Yes, and we also already sent those links in the letters.
Oh, okay. So we'll just reference the letters for everybody. You can see these links in the letters. Thank you.
Yes. All right. So first on the technical manual is divided into various sections. So section 1 provides an overview of how the benchmark was calculated. And I missed it, but Mandy probably mentioned that the benchmark is determined by a combination of wage growth and potential state income growth. And then section 2 discusses how statewide carrier and provider healthcare cost growth or performance are measured against the benchmark. No benchmark comparison was done for the data collected in the first data call, but the first performance comparison against the benchmark will be done for the first time on the 2022 data, which will be collected during this year's data call, as mentioned in the previous slide. Section 3 provides very detailed instructions to carriers on how to prepare and submit data. To do so, submitters must correctly populate and submit the data submission template, which we will discuss in the next slide. Next slide, please. So the data submission template has 6 tabs. If you can click that, Ross. Yes. The cover page, the TME tab or the total medical expense tab, the standard deviation tab, the enrollment by line of business, and the RX rebate tab, as well as the reference tables. Next click, please. For the next slides, we will discuss the content of the cover page. Next one. Then we will proceed to the TME tab, where we will explain the data stratifications required, specifically going by carrier code, reporting year, insurance category code, large provider entity code, age band, and sex code. We'll also discuss the data fields that are needed to populate this tab. We will focus on explaining the calculation of truncated claim spending. Next click, Ross. Which tended to be incorrectly calculated based on the last data call. Then we will move on to the third tab, which is the SD tab. This requires submitters to submit the standard deviation by carrier code, reporting year, large provider entity code, and the market code. As in the TME code, submitters need to submit the member months, the truncated claims spending, and what's new in this tab is the calculation of the standard deviation of the truncated claims spending, PMPM, which we will discuss in details and provide an example in the later part of this presentation. We'll then move on to the fourth tab, which is the LOB or line of business enrollment, which asks submitters to provide member months by carrier code and line of business categories. And then we'll also explain what's being asked in the RX rebate tab, which asks details on pharmacy rebates by carrier code, reporting year, and insurance category code. We will refer to the reference tables, which is the 6th tab, as we explain the different data stratifications in the various tabs of the template. Next slide. So the first tab of the template is the cover page. In this page, carriers are asked to provide the contact information of an individual who we should contact during the data validation process. Next click. There is also a section in the cover page that asks submitters to confirm estimation methodologies that are used in the numbers submitted, as well as to provide information on the completeness of claims data used. In this page, an authorized representative is going to attest the currency, completeness, and accuracy of the data submission. These authorized representatives should be done by a chief medical officer, the chief data officer, or other executive of the carrier. Next slide, please. Moving on to the second tab, which is the TME tab. The data that will be provided in this tab should be grouped by carrier code. Next click, Russ. Yes. Carrier code, reporting year, insurance category, large provider entity code, H band, and sex code. These codes can be found in tab 6 of the reference tables. Next click. Thank you. And then next slide. One of the data strata is the insurance category code for the TME tab. The insurance category codes, or ICCs, are mutually exclusive codes, categories that indicate for which business the carrier is reporting data. The right-hand box contains the various codes for the ICCs. Next click. Notice that for the commercial insurance category code, it has 2 subcategories. Those are the full claims. Click. And the full claims is for when the carrier holds the entire medical benefit and has all the data, while the partial claims are for when the carrier holds part of the benefit and another part is carved out. For example, of these carved out benefits are pharmacy and behavioral health. Carriers should estimate partial claims data for which the carriers do not have access. So for example, if the carriers may use data from their full claims commercial market to impute per member spending on pharmacy for the partial claims category. Next slide, please. For this data call, 2 other insurance categories were also added to the set of ICC codes. This change is only for carriers that cover a portion of federal employee health benefits, or FEP, for a group of members, while another carrier covers the other portion. Next click, please. Another one. These codes are insurance category, FEP full claims 7 and FEP partial claims 8. It is very important to note that if you do not share coverage of FEP members with another carrier, please ignore this change and categorize FEP spending in the commercial insurance categories. Next slide, please. For this data call, one more, yeah. For this data call, there are also additional codes to submit spending information without age and sex stratification. If the claims have unknown sex and unknown age, we have codes for this as well. Specifically for claims with unknown sex category, the code should be code 3, and for unknown age, the code should be code 9. Next slide. Another data stratification in the TME tab, as well as in other tabs, is by large provider category, and Ross will further explain how to group the data by large provider category. Ross?
Thank you, Cheryl. All right, so we'll talk a little bit about the large provider entity code. This is the list of large provider entities we have. You're going to hear me say this a lot during the presentation. We're doing an overview more for a lot of this, so please refer to the technical manual for more detailed information. And after looking at the technical manual, if you still have questions, please reach out to us. We'll have an email at the end of this presentation where you can reach us easily. So this is the long list of provider entities. The few I want to point out is that for code 100, this is for the carrier overall. So when we get to the standard deviation section, we need the standard deviation for the carrier overall. And so we want to see that in the standard deviation tab. We'll talk more about that in a bit, but we do not need large provider entity code 100 in the TME tab because we can just sum everything up. So just wanted to make sure everybody understood where and where we do not want carrier overall information. Then the next 33 codes are for the list of potentially large provider entity codes. Please, like you did last time, separate out your spending based on these entities. And if you if you cannot associate spending with any of these larger entities, please associate everything with the provider entity code 999, meaning it's not attributable to one of these other entity codes. So for reporting, for associating the spending to these provider entities, we like to use the following hierarchy. So first, attribute an individual to a primary care provider, and then those primary care providers to the larger provider entity. And then the hierarchy for that is first, member selection. So please associate members who are required to select a PCP by design. If that doesn't come up, please associate them based on contract arrangement. So members not included in the above and who can be attributed to a PCP during the performance period based on a contract, please do so in that way. And then finally, if the other two do not work, please associate spending based on utilization of the PCP. Moving to which spending we would like to include, we would like to include spending based on Washington residents. And please report the allowed amounts for the residents. And we also only want you to include spending where the insurer is the primary payer. Please allow for a runout period of 180 days and a non-claims reconciliation period of the same amount, 180 days. Please apply reasonable and appropriate incurred but not reported or incurred but not paid completion factors to each TME service category. And please apply reasonable and appropriate estimates of non-claims liability that are expected to be reconciled after the 180-day period. Some examples of included policies, would be things such as self-insured plans, student health plans, PEB-SEB, the Federal Employee Health Benefit Plans, Medicare HMOs, PMOs, HMOs, PPOs, SNPs, and then for Medicaid and CHIP managed care contracts. Some examples of excluded plans are things where they are not fully covered. So accident disabilities, standalone prescription plans, so Medigap, long-term insurance care, stop-loss plans, vision only, dental only, workers' compensation. Please do not include these plans or this spending as well. Then I will transition into some more of the data fields. So for a high-level view, we would like the number of member months associated with each stratification. And then for the TME 08 through 15, we're going to ask for a set of service categories based on claim spending, which we'll go over in just a minute. For the columns 16 through 21, we will look at some non-claims-based spending. And then for column number 22, this is where the truncated claim spending will be listed. And then for the 23rd column, this will be the count of members who had truncated claims. So just to highlight again, only TME 22 should have the truncated claim spending. Just trying to make sure we remove some confusion that happened last time based on truncated claim spending column to help ease validation as well as reporting later on, reporting and analysis. So in the column header, you can see where we say non-negative number or non-negative integer for count of members. This is true across the board except for recovery, which is TME 20. That should be reported as a non-positive number, so a negative number. Because of the way the recovery works and is bundled in, that helps with our processing of these claim spending, or rather non-claim spending. Now to dive into each field a little bit more. This is again going to be a high level. Please refer to the technical manual for more information. But the first column is hospital inpatient. So this would be all room and board and ancillary payments for hospitals. This includes payments for emergency room services when the member is admitted to the hospital. Things that are not included in hospital inpatient are payments made for observation services, or payments for physicians or physician services that are provided during inpatient stay that have been billed directly by the physician group practice or an individual physician, as well as do not include inpatient services at non-hospital facilities. For some of the allowed amounts for the hospital outpatient spending, please include all hospital types and payments made for hospital licensed satellite clinics, emergency room services that did not result in an admittance, and observation services. And again, please do not include payments made to physicians on an outpatient basis that have been billed directly by the physician group practice or an individual physician. Now we get into professional spending. So our first one on this list would be primary care providers. So this is some of the allowed amount for claims paid to primary care providers for primary care services. We have supplied the primary care taxonomy and procedure codes in the technical manual as attachment 1 and attachment 2. Attachment 1 including the taxonomy codes for primary care providers, and attachment 2 being the services that are defined as primary care services. I do not think this definition has been updated, or rather changed, since the last submission, but please refer to the technical manual to make sure that we are all using the same services counting the same services for primary care. Next up is the professional specialty providers. And so this would be the sum of the allowed amounts from the claims paid to physicians or physician groups that are not defined as primary care. And this includes services provided by like a doctor of medicine in clinical areas other than family practice, geriatrics, internal medicine, and pediatrics. Yep. So specialty providers should go in the professional specialty providers column. And then the last professional column we have are the other providers. And so this would be some of the allowed amounts paid to a licensed practitioner other than a primary care provider or specialty provider. So some examples, but not limited to these things, such as dentists, dietitians, psychologists, licensed nurse practitioners, physician assistants. So also, please include any fees that do not fit other categories, including facility fees of community health center services and freestanding ambulatory surgical center services. The next field we're going to look at is long-term care. So the sum of spending from claims paid to healthcare providers for skilled custodian nursing facility services, intermediate care facilities, and services for persons with developmental disabilities, hospice, providers of home, community-based services, including personal care, homemaker and chore services, home delivery, meal program, home health services, adult daycare, self-directed personal assistance services, and programs designed to assist individuals with long-term care. Please do not include payments made for professional services rendered during facility stay that had already been billed directly by a physician group practice or an individual practitioner. And the next field we're going to talk about is retail pharmacy. So this is the sum of allowed amounts from claims paid to retail pharmacies for prescription drugs, biological products, or vaccines. This category should not include claims paid for pharmaceuticals under the carrier's medical benefit. Pharmacy payments made under the medical benefit should be attributed to the setting in which it was delivered. So an example would be if it was delivered under the claims hospital inpatient category. Medicare Advantage carriers that offer standalone prescription drug plans, or PDPs, should exclude standalone PDP spending from their reporting. Additionally, pharmacy data should be reported gross of applicable rebates. We will have a section in the template later for doing overall rebates, but for retail pharmacy in the TME tab, please report retail pharmacy gross of rebates. Then we come to the last claims-based spending field, the other field. So this is the sum of the allowed amounts of claims paid to healthcare providers for medical services not otherwise included in the other categories. So this would be things such as durable medical equipment, freestanding diagnostic facility services, hearing aid services, optical services. Payments made to members for direct reimbursement of healthcare benefits/services may be reported in claims other if the carrier is unable to classify the service. And now we're going to transition to non-claims-based spending fields. The first one we're going to talk about is capitation or bundled payments. And so this would include all non-claims-based payments made to cover healthcare services, including capitation, global budget, case rate, episode-based payments, all of those things. Performance incentive payments are all payments made to providers for achievement of specific predefined goals for quality, cost reduction, or infrastructure development, such as pay for reporting or pay for performance. This also includes shared savings distributions and shared risk recoupments. Next up, we have population health and practice infrastructure payments. So all payments made to providers to develop capacity and practice infrastructure to help coordinate care, improve quality, and control cost. This includes things such as the electronic health record or health information technology infrastructure payments, patient-centered medical home recognition payments, primary care and behavioral health integration payments that are not reimbursable through claims. The next category is provider salaries. So all payments for salaries to providers who provide healthcare services not otherwise included in claims and other non-claims categories. For the last two, we have recovery. So all payments recouped during the measurement year as the result of a prior review, audit, investigation. This field should be reported as a negative number and only report data in this column that is not otherwise included elsewhere, such as if inpatient hospital is reported net of recovery, please do not separately report the same recovery amount in this column. And then the last non-claims-based column, the other column, this is for all other payments made pursuant to the carrier's contract with a provider that were not made based on a claim for healthcare benefits/services and that cannot be properly classified elsewhere. This could include things such as governmental payer shortfall payments, some grants, or other surplus payments. It might also include Medicaid Transformation Project, or MTP, payments made directly by carriers to providers, and only payments made to providers are to be reported. Carrier administrative expenditures, corporate allocations are not included in TME. All right, now we're going to pass it back to Cheryl.
Yes, so the last two columns of the TME tab are related to truncation. The first truncated related variable is the truncated claims spending, and the other one is the count of members with truncated claims. So truncation means that spending above a certain threshold is not included. That is, spending of certain high-cost members is capped at the threshold to prevent a certain few individuals from skewing a provider or carrier's overall cost growth. Truncation is applied on claims spending, inclusive of all carved-out spending estimates for partial claims. And as we mentioned before, this is when you estimate for benefits that are covered by other entities. And then truncation is also applied on a per member basis, and we'll provide an example to clarify this one. So truncation has different thresholds for various insurance categories. So for example, this table that was provided in the technical manual shows that the truncation threshold for commercial is 200,000, while the truncation threshold for Medicare expenses for Medicare and Medicaid dual eligible is 125,000. So it varies by ICCs. Next slide, please. A common mistake that we saw in the last data call was that carriers submit the truncated claim spending as the amount above the truncation threshold. The correct way to do this is to report the amount below or at most the truncation threshold. Next click, please. So once each member's spending has been truncated, the data submission template asks for the sum of claims spending after truncation has been applied. And this information, next click, please, is for the total medical expense tab, TME 22 column, and the standard deviation tab, SDO6 column. So here's an example of the truncation. Suppose we have commercial claims market. We're talking about the commercial claims market. Next click, please. We have 5 members for the commercial claims market. And since this is the commercial claims market, we're going to compare each member's untruncated claims spending to the commercial threshold. Next click, please. So if you can refer to table A8 of the manual, the truncation threshold for commercial is 200,000. Next click, please. So we're going to look at each member. Next click, please. Before that. Yes, thank you. So we're going to look at each member's untruncated claims spending. So member 1, for example, has 150,000 for the whole year, and member 5 has 250,000 for the whole year. Next click, please. We're going to compare each member's individual spending to the threshold, which is 200,000 for the commercial ICC code. Next click, please. So we'll see that for each member 1, for example, the amount above truncation is 0 because it did not exceed the truncation threshold, while member 4, for example, exceeded the threshold by 25,000, and member 5 exceeded the threshold by 50,000. So the truncated claim spending, next click, please. If you sum up the amount above truncation threshold, the total is 75,000. And some carriers' common mistake was to report 75,000. This is not what we ask in TME 22 or SDO 6. Rather, next click, please. What we ask is that we get like the total truncated members for total truncated claim spending for each member that is below or at most the truncated threshold. So for example, member 1 has 150,000, member 4 has 200,000, and member 5 has 200,000. So if you sum all this truncated claim spending, that is $925,000. And this is the value that we ask you to populate for TME 22 in TME tab and SDO 6 for the standard deviation tab. Next slide, please. Are there any? I guess we'll do the question answer later.
Ariel, I've been monitoring. I don't see any hands raised.
Okay.
If that's what you were going to ask.
Yeah. Yeah. Thank you, Mandy. Now we're moving to the standard deviation tab. So in here, submitters calculate and provide, next click, please, the member months, the truncated claims spending, and the standard deviation PMPM. And this data will be stratified by carrier code. Next click, please. Reporting year, market code, and large provider entity code. Next slide. The standard deviation is used to calculate the confidence interval of the cost growth of carriers and providers, which will be compared against the benchmark growth rate. It is important that submitters not just provide the standard deviation for each of the providers, but also for the overall carrier for each market each year. When providing the standard deviation for the overall carrier, the large provider entity code for that row is going to be 100. Note that the submitters, as mentioned by Ross earlier, do not need the provider overall carrier in other tabs, only for the standard deviation tab. Submitters must also group those that are not considered large provider, as explained by Ross earlier, under large provider code 999, and provide standard deviation for this group as well. Provider in a particular market, the submitter must have a standard deviation for the overall carrier in that market, and that is the large provider entity code equals 100, and also the standard deviation for the provider entity, even if the large entity code is 999 and the values of these two rows are equal. We'll provide an example in the next slide. So this is an example of how many rows we expect, how many rows of standard deviation we expect in the standard deviation tab. So suppose for a particular year, a carrier operates in the following markets, in the Medicare as well as in the Medicaid market. And the carrier has corresponding contracts with this certain number of providers. So for Medicare, they contract with 3 large providers and 2 non-large providers. And for Medicaid, the carrier contracted with 2 large providers and 0 non-large providers. For the standard deviation tab, there will be 8 rows for this particular case. So there will be 2 rows for the overall standard deviation for the Medicare and Medicaid markets. In this scenario, for these 2 rows, the large entity code will be 100. And then there will be 4 rows for the Medicare market, 1 row for each of the large providers, and 1 standard deviation for the group of the 2 non-large providers in the Medicare market. These 2 non-large providers are going to be lumped under large provider code 999 or unattributed to a large provider. For the Medicaid market, we expect 2 rows for the 2 large providers, so 2 standard deviation for each of the large provider. And since there are no non-large provider, there will be no standard deviation for code 999. So for this one, in addition to stratifying the standard deviation data by carrier, provider, and year, the standard deviation should also be aggregated by market code. For carriers with FEP members, please include this in the commercial market. So we expect to get 1 standard deviation only for the commercial market, which includes all the FEP clients. Next slide, please. When calculating the standard deviation, submitters must use the average monthly spending amount in contrast to the actual monthly spending of each member using claims-based allowed amounts after partial claims adjustments and truncated claims spending as instructed in the previous slides. It's also important to note that non-claims-based spending should be excluded when calculating for the standard deviation. We will walk through an example in an Excel file. May I share my screen now? Because we're going to use the Excel file that is attached in the webinar invite.
Yes, Sherry, you should be able to share your screen.
Okay. So
Ross may need to unshare his, but yes.
Oh,
I can see the share button. Are you able to see my screen?
Yes.
Okay. So this is an example. So suppose in 2022, these are the actual truncated claim spending. Note that we're working on actual truncated claim spending by month for attributed members of carrier A in the commercial market. So suppose there are 3 members for carrier A in the commercial market. Member 1 has 100 actual monthly spending for each month in 2022. Member 2 has 5 months of coverage, and these are member 2's actual monthly spending. And member 3 has 12 months of coverage, but only in January has this member has 500 spending and the rest were 0. So to calculate the standard deviation, we're going to get the average monthly spending of each member. For member 2, we only have 5 months of coverage. Member 3, we have 12 months of coverage. So member months for member 1 will be 12. Member 2 will be 5, and member 3 will be 12. Albeit the rest of the 11 months have 0 spending. So to calculate the standard deviation, we are going to use the average monthly spending. So for member 1, for example, the average monthly spending is 100. So we're gonna put 100 and put it for the rest of the monthly spending. And for member 2, the average monthly spending is also 100. So for this, we're gonna put 100. And the person, member 2 has 5 5 member months. So we have 5 member months in our array. For member 3, the average is 41.67. And member 3 has 12 months of coverage. So this one should be also 12 months of coverage. I'm gonna format that. Be the same. Now we're going to use the standard deviation function. And note that we're going to use the P here because we're using data from the population and not from the sample. So we're actually going to use this function to get the standard deviation. So the standard deviation for the truncated claims PMPM for carrier A in commercial market is $28.73. A common error that we see may happen in the calculation of the standard deviation is that carriers will actually use the actual monthly spending. So this could happen. Instead of using the average monthly spending, we get the actual monthly spending. So for member 2, this one will be here. And then member 3, this will be here. So if you use the actual monthly spending and get the standard deviation, what would happen is the standard deviation is actually going to be larger than expected. So we would like to emphasize that in the calculation of the standard deviation, the submitters must be very careful to use the average monthly spending in the array and not the actual monthly spending. And I'm going to turn back to Ross to continue with the presentation with the slide sharing.
Second, and share. There we go. All right, I think everybody can see my screen now. So we are back in the slideshow where we left off. So now we will pick up with the line of business tab, or LOB. So for this tab, we have LOB 02 pre-filled out for each line of business. This covers things such as large and small group, student health plans, and then the other Medicaid, Medicare lines of business. This helps us fill out things such as the net cost of private health insurance calculations for later. So that's why I have these line of business rows already filled out, or not rows, but LOB 02 filled out so that we can get the member months for 2020, 21, and 22. For the prescription rebates tab, this is where we mentioned previously about putting in the pharmacy rebate amounts stratified by carrier code, reporting here, and insurance category code. So we have 3 different fields for rebates. We understand that it may be difficult to separate out rebates between medical pharmacy and retail pharmacy. So if you cannot split those apart into medical and retail rebates, you can go ahead and put everything into total pharmacy rebate amounts, the RXR06, the one that says optional. If you are able to parse both of those out, then please put them in their appropriate column. And then the last tab has reference tabs or reference tables. So things such as what our insurance category codes are, market codes, line of business codes, age and sex codes, the large provider entity codes, the carrier codes, and then the valid years for the data call. When you get all your information into the template, please do a quick scan, as we have set in conditional formatting, to highlight if one of the codes do not match the reference tables. So for instance, maybe a year got listed as 2023 by accident, or maybe sex code was set to -1 for unknown. Please just do a quick scan to see if there are any red fields that pop up so that we can potentially fix some validation issues down early instead of down the line and having to do more resubmissions based on the data. I will also go over a couple of suggested consistency checks. These are things that we ran into in the last data call, and if we can get these like pre-checked or even get past these on the first submission, it will help make the whole process go by much more easily and much faster, since we're not going to have to do these checks. I say not, we're still going to do them, but then it will be less of a question that will pop up. So please double check that the sum of the TME 22, which is the truncated claims pending, in the TME tab is equal to the sum of the total claims truncated spending in the SD tab. Please note that in the SD tab, you're going to have to take into account the overall, the carrier overall provider entity code of 100. So you might see some things if you just tally up both columns, one column is going to be double what the other one is. So please keep that in mind, but the total truncated claim spending should be equal in both tabs, taking into account removing the overall provider, overall carrier code of 100. Also, please double check that the number of member months in the TME tab is equal to the sum of member months in the SD tab, as well as the sum of member months in the line of business tab. Again, taking into account carrier overall of large provider entity code 100. Now to do this one, there's going to be a little bit of a crosswalk that's going to need to be done, because the line of business is set up to do things such as large and small, student health plans, and those sorts of things. So commercial is going to need to be just lumped up into commercial overall, but then the other categories should be able to have a direct path to each other. Shouldn't need a crosswalk for that. And then I will hand it back to Cheryl for some submission reminders.
Thank you, Ross. Next slide, please. So, so given all the details on how to prepare and submit the data, these are some reminders of on the deadlines and how to submit. So the data submission deadline is May 15, 2024. Next, this is an extension from the original April 15 deadline. We will send 2 weeks before the deadline on May 15, we will send a gentle reminder that the deadline is coming up soon. We'll also do that 1 week before the deadline. Once you populate the data, and it doesn't have to be on May 15, you can start submitting the data to this email address. Please note that there is a change in the email address from the previous one. The HCA cost board data is exclusively for data submitting and as well as submitting data questions. On using the Excel template file, please be careful to not create new columns or create header names or include column or row totals in any of the tabs. Those one will be automatically detected in the technical validation, and that will be returned to the carriers to clean up the template. Next slide, please. If an unexpected code or value is put into a cell, the cell will turn red, as explained by Ross. So for example, if a provider entity is spelled out instead of the code for that provider entity, the cell will turn red. Please also ensure that any calculation done to check for data accuracy and consistency in the checks are deleted before submitting. We also have an updated file naming rule, and this one will be strictly followed as ingestion will not happen if the file naming rule is violated. So please ensure that before you submit the file that you follow this file naming format. The first few characters will be the carrier code, underscore the carrier name, underscore TME, and the date of submission. And we have an example in the technical manual. Next click, please. So once carriers or submitters submit the data, we will validate the data and check for cell syntax, data consistency, cost growth, outliers, and other factors. If we find any data issues and if we have any questions, we will contact the contact person in the cover page, as specified in the cover page. And since we only have 2 weeks to validate the data and make sure that we meet all the deadlines, based on the legislation mandates, carriers have 1 week to resubmit the data. This is going to be an iterative process until the data gets fully validated and accepted. So carriers are welcome to ask questions anytime via email. Again, the data related email address is this email address. Next click, please. We also have a separate time allocated for private consultation one-on-one with carriers. And we set these office hours to be March 11 to March 15. So that's Monday to Friday from 9 to 11 a.m. To be able to avail of the office hours, kindly email HC Cost Board data at hca.wa.gov. And we'll send you a link to select the slots that are not yet chosen. So appointments will be on a first come, first serve basis. And that ends the presentation for today. We now welcome any questions from our carriers.
Please go ahead and raise your hand if you'd like to ask a question. Cheryl, as an update, we'll give it another minute, but I don't see any hands raised at this time.
Okay.
Oh, I see one. Hold on, I'll find it. Ashley West. Hold on just 1 second. Go ahead, Ashley. Ashley, are you able to talk? I see a hand raised. Oh, go ahead.
I'm sorry, I guess my mic was still on mute. Hi, my name's Ashley and I'm with one of the carriers. One of the items that I did find interesting and kind of had as a question for you guys is the large provider entity codes. So one of them stuck out where I think, I don't know the full name, but I know it was Homeless Network Insurance provided by Seattle County, I think might have been the name. The federal tax ID, would you guys ever be able to, I guess, provide their tax IDs that would go along with those large provider entity codes to make them more accessible to align with medical claims or pharmacy claims that are billed to the carriers?
Thank you, Ashley, for your question. Ross, would you like to provide more answer to that?
Sure thing. So we are investigating ways to make the association process easier. I know some other cost boards use TINs, tax identification numbers. You mentioned that. But we do not have a concrete list yet, but that is something that we are looking into for process improvement in the future.
Thank you. That would be most appreciated.
Ashley, do you have any other questions?
I have no further questions. Thank you.
Okay, if you have one later, just raise your hand again, okay?
Okay, thank you.
Kim, I see Kim K, Kim with 2 M's.
Yes.
Go ahead, Kim.
Hi. I wanted to just get some clarity around the federal members, since that's sort of new. Like, for example, we are pulling the federal members that have our carrier listed as the primary payer. But then when I look at the actual claims data, sorry, let me backtrack, where we're not listed as the primary payer. But then when I look at the actual claims data, there are some claims where we are the primary payer, even though as a member, the member is not listed as having us as a primary payer. So would I consider that, do I go by how their membership is structured, or should I go by how the claim was paid?
Yeah, thank you for the question. Ross, do you have any answer to that?
That is a good question. Will you please email us that question in the board box so that we can have a little bit more time to think about it?
Yeah.
Sure, no
Thank you.
problem, no problem. And also, if if federal is listed as the primary, but they also have Medicare, should I still list them as a commercial member, or should I list them separately as federal because they also have Medicare?
I think we have some documentation on that question. Please email the data board box for that, and we'll get back to you as soon as we can.
Okay, those are my two main questions, but I look forward to hopefully grabbing one of those slots when you have open office hours. Thank you.
Thank you. Thank you.
I see Casey from UHC.
Yes, I had a quick question. In our previous years, we had submitted 3 separate files for commercial Medicare and Medicaid. With your new naming convention, are we allowed to do that again this year?
Yes, so I think we highly we ask that you consolidate all the spending and like the data submission into one into one Excel file. So the data template should allow you to be able to like append the different rows for each of the market.
So you want it consolidated into one file. The only reason why I'm asking is just in case we have a roadblock, say for Medicare, we want to be able to submit for commercial and Medicaid in a timely manner.
Ross, do you have any like answer to that based on your previous experience?
No, that sounds like a question for our data management specialist. I do not think is on the call today. So go ahead, Cheryl.
Yeah, we'll take note of your question and then we'll get back to you. If you can also like email that question so that we have that listed and consult with our data management specialist to see if that's possible.
Okay, will do. Thank you.
Thank you.
I don't see any other hand raised, but I just want to give an opportunity for anybody who hasn't raised their hand yet to go ahead and ask a question. Sherry Ellen Ross, I don't see any other hands raised, and I think that probably brings us to the end of Q&A.
Thank you so much to all the carriers who have attended this meeting. Again, your questions are welcome anytime, so please email us using our email address, and also we look forward to meeting all of you or some of you during the one-to-one meeting during the office hours. We have attached the slides in the webinar invite, as well as the Excel file for the standard deviation example.
All right, if there aren't any other questions, it sounds like we're at the end. Sherry Ellen Ross?
Yes, that's all from us.
Sounds great. Hope you have a great rest of your day. And again, if you'd like to set up some office hours, please email the box and we'll get you set up with some office hours if you'd like additional and that you might have, and we'll get you those responses as well. Thank you again, everybody, for joining us today. We really appreciate your efforts in this. Have a great day, everyone.